artificial intelligence. I'll be sharing my screen. So hi everyone, the talk will be called From Mountains to Microns, Ophthalmic Imaging and AI. I am Jad. I'm a postdoctoral scholar at KCI Institute in Portland, Oregon. My background is in medicine. However, I did a lot of research in computer science and artificial intelligence. And I would love to share some insights with you in my journey in ophthalmology and artificial intelligence, and mainly ophthalmic imaging. So when we look at mountains, this is a topographic map. When we look at mountains, we want to be able to translate them from three-dimensional volumetric structures to 2D maps where we could easily read them and understand them. So on this topographic map, we noticed that we were able to summarize this elevation map of the mountain into a topographic map. And each line represents the same altitude or the same elevation. And this way we are able to put this map into context and imagine how the mountain would look like on a 2D surface. Equally speaking, this is also done on the eye. This is the cornea, which is the anterior-most surface of the eye, and we can also transform it into an elevation map to be able to understand its shape, understand if it's healthy or diseased, and try to assess whether a patient is healing well or needs treatment. Some diseases of the cornea happen by uh, a change in the topographic map of this cornea. Some diseases weaken the cornea, and that means that the cornea would have some sort of a bulge or some sort of a cone, and we call this keratoconus. Many other diseases also exist that present differently. So each cornea essentially has a distinctive shape, and this can be imaged and transformed into a topography map for the physicians to read and interpret. And a relatively new imaging modality in ophthalmology is optical coherence tomography, or OCT for short. It allows us to image the eye in 3 dimensions and in depth. A very important characteristic of the eye is that it's composed mainly of transparent structures. And by having that, we can have light penetrate the eye and image multiple layers of the eye, as we see here. We will be focusing mainly in this talk on the cornea, which is my area of specialty. This is the cornea, which is the anterior-most portion of the eye, and it is very transparent, which allows light to come in and reflect on the retina. This is another image of a much more zoomed in cornea taken by OCT. And I'm going to show you briefly how we can transform this into a topography. We can notice multiple layers of this cornea. And using some form of AI or segmentation algorithm, in this case, I'm using an NNUnet to segment this cornea. We can segment it into multiple layers, the air, the epithelium, the stroma, and the aqueous humor. To transform it into a topography map, we care about the epithelium and the stroma. And if we get enough cuts over an eye in multiple angles, such as in this case, this is an 8-cut radial scan pattern, we can overlay these segmentations and convert the cornea into a topographic map. We call it a corneal topography. And this is the basis of a lot of cornea imaging as well as retina imaging. And these, in this case, areas of similar colors represent similar elevation points. And this is an elevation map of the cornea. We can take this elevation map of the cornea and apply multiple mathematical formulas on this map specifically and convert this elevation map into curvature maps, thickness maps, elevation of the front part of the cornea or of the back part of the cornea, epithelial thickness maps, so on and so forth. Multiple maps can be derived from this main segmentation that we've taken. And all of these are helpful to understand the different aspects of the corneal shape. This can guide treatment, this can guide diagnosis, and a lot of diseases can be detected from looking at the corneal topography or tomography. One main part of my research focus with Haidar is that we are focusing our efforts on these topographic maps to try and diagnose keratoconus. Keratoconus is a bulging of the cornea, uh, and it's very prevalent in the Middle East as well as the Mediterranean area. Basically, the cornea weakens, it bulges out, and then this leads to refractive error that cannot be correct even by glasses. And it's not reversible unless you do a very invasive surgery. So ideally, we need to detect and diagnose keratoconus as early as possible to be able to halt its progression using using a specific surgery. And for that, we need to look at topography maps to be able to understand whether a cornea is actually progressing or not, or actually has features of keratoconus or not. One of our projects was to derive and come up with a thickness speed progression index, which is an index of the thickness progression of the cornea, basically. On the left, we can see a corneal thickness map, and has been a staple in one of the main maps that we see out of a topography image. And using this map, we noticed a very interesting pattern in eyes that have keratoconus. And we thought of deriving this map and converting it to a thickness speed map instead of a pure thickness map. We wanted to understand how does thickness change uh, relating to position. And we got this map on the right as a derivative, as a radial derivative of the map on the left. And if we look at this map on the right, we were able to extract uh, different biomarkers from this map by doing a search over different arcs at different diameters. And we were able to come up with 6 features in total that kind of summarize this map properly. We fed these features into a machine learning model that we call the TSPI, Thickness Speed Progression Index. We tried multiple machine learning models, including logistic regression, SVM, AdaBoost, and random forest. And we finally obtained this confusion matrix on the test set. Basically, we have 3 classes we wanted to predict. We have patients that are normal, patients that are keratoconic, and severe keratoconus, basically. And you have patients in between. This is where science is not very clear about the diagnosis of these cases, which is why we're trying to come up with an index with the thickness map of the cornea to try to understand these cases. So the algorithm, the index was highly sensitive and specific for keratoconus as well as normal cases, and understandably less accurate in keratoconus suspects because we don't have a standard way of diagnosing these patients. Eventually, we published this paper in the American Journal of Ophthalmology, as well as many other papers relating to analysis of topographic features that relate to keratoconus. So that's essentially how a topography can inform diagnosis. It can also inform treatment and surgery, but that's for a later discussion. But I wanted to kind of give a software perspective on topography and tomography and how they can be integrated with machine learning. And essentially, the reason we did this feature concatenation, uh, as we just showed here, is because we have a map that has tens of thousands of points, and we wanted to kind of summarize it in a meaningful and simple way. We usually have very few hundred patients in a data set when we're training an AI model in medicine. And it's really rare to see to see data sets with more than 1,000 patients in total. So our options in terms of machine learning are very limited. Uh, in this case, our data set was small, and we had to engineer the features in order to get as little features as possible and feed them into a machine learning model that made sense. And this also increases trust with an index when we know that these indices have a mathematical component, a basis rooted in some calculations. A lot of the scientists and researchers will trust more this algorithm, and they will use it. Are more likely to use it as well as approve it for diagnosis. And a lot of research can be done on topographic maps, whether it's on the cornea, whether it's on the retina. There's a lot of ongoing research, and I would say the bulk of ophthalmic research lies in tomography and topography of the eye. It's not just about tomographic maps, but also a lot of research happens on the reflections of the sections. If we look at the OCT sections that we previously had, as seen in here, for example, we can use these to detect opacities, irregularities of the epithelium, etc. And a lack of transparency in the cornea can be transformed into some sort of a opacity map or a dystrophy map that can inform as well diagnosis and treatment and so on. So there's a lot of software component that could be plugged in into ophthalmology and topography for diagnosis and so on. Moving on, if an ophthalmologist or a clinician wants to image parts of the eye or the cornea with a higher resolution, what can one do? So in this case, the OCT that we're seeing here can only image at about 3 to 5 microns in axial resolution. The transverse resolution is even worse. So we cannot image a lot of things, including nerve cells, bacteria, fungus, and so on. So for this reason, we have to resort to microscopy. And microscopy is a very important modality in all of medicine, not just ophthalmology. There's even a specialty called pathology that relies on microscopy. And they basically cater to a lot of, to all of medicine in terms of disease detection and diagnosis. And microscopy is very frequently used in ophthalmology as well. And one main reason we do that is to detect whether a cornea infection or an eye infection has bacteria in it or fungus in it. So on the left, we see the bacteria, that's a special stain for bacterial imaging. And on the right, it's a KOH smear, which is a special stain for fungus imaging. So the infection of a cornea is called infectious keratitis. It's a leading cause of blindness worldwide, with more than 2 million cases of preventable vision loss per year. So it's a big problem worldwide, and it happens in a lot of developing countries. These two modalities that we just talked about, the microscopy evaluation of infectious keratitis, offers point of care diagnosis, which means as soon as we get a patient, we can understand whether he has a bacterial infection or a fungal infection. And microscopy is relatively inexpensive. Most clinics and labs have a microscope, and it just requires a simple preparation that any clinician can do. So this microscopy is one of the simplest, most effective tests in understanding the infection that we're dealing with to guide proper treatment. And unfortunately, understanding these microscopy images and slides is a bit difficult. Not all specialists can read microscopy images. It requires a certain skill to kind of image the sample properly and properly interpret the results. And for this reason, we decided to try to come up with an AI model on microscopy images and try to digitize these images and assist clinicians in their interpretation of of microbial keratitis microscopy. Essentially, we hooked up a microscope with a camera and we digitized an entire slide at very high magnification. And to do that, we have to collate multiple patches together through a specialized software for whole slide imaging. These are available online. And this is how we can convert a slide on a glass slide to a digitized whole slide image. This is one example from a fungal infection. We can take patches and visualize them at higher magnification. On the bottom right, there's a 20x magnification patch that shows a very fine filament, and this filament comes from a fungal infection, which tells you that sometimes all it takes is one or two patches to solidify our diagnosis. So how can we use artificial intelligence on this sort of images to try and come up with an interpretation or a diagnosis or classification in machine learning terms? The challenge in this case is that these images are about 200 times larger than the typical images we use for AI. Their resolution can stem from few thousand pixels to few hundreds of thousands of pixels, depending on how large the slide is and how high the magnification you're using is. So for this reason, we decided to use a multiple instance learning framework for our algorithm. Essentially, I took the whole slide image, I cut it into non-overlapping patches at multiple magnifications, so at 20x magnification and as at 10x magnification. These two magnifications help us get enough resolution as well as enough gross morphology from the slide. We fed these into a feature extraction encoder, which is in this case a ResNet 18 that I used, that I trained using contrastive loss. It's a SimCLR essentially. And we were able to transform every patch into a feature vector. And this feature vector can be is essentially a vector of 500 features, which is much smaller in size than the patch that's about 250 by 250 in resolution. So once we have feature vectors from all of these patches on the entire whole slide image, we can aggregate them and feed them into a transformer, which is called a DSMIL network that I used. And we are able to classify the entire slide as fungus positive or fungus negative. So in this case, because we don't have a patch level labeled, we only have a slide level label. This is one of the most efficient ways of doing so while trying to keep context of the whole slide image. Essentially, what we want to reach is that you image the entire slide, and this algorithm would be able to tell you whether there's a fungus or not in that case. We're able to reach pretty good accuracies with an AUC nearing 90% and an accuracy nearing 80%. We were also able to use this MIL, multiple instance learning network, to give us heat maps. And if we zoom in, we can notice that these heat maps flag areas that have some filaments in them. So this helps assist in the interpretation of the slide, and it kind of makes the black box model less of a black box. This work was also published in Ophthalmology Science, and we were also interested in replicating the similar work, but on bacterial keratitis. So the first work was on fungal keratitis, where we image fungus filaments on microscopy, but now we wanted to work with bacteria. And bacteria is of a much smaller scale than fungus. In the previous image we were taking patches at 10 and 20x magnification. That's all it took. But in this case, we're going to need a 40x magnification. Even in the labs, they usually use 100x magnification to image bacteria. So if we look at the right panel in this case, these small dots may or may not be bacteria. We have to look at them carefully, try to see their morphology and whether they are of the right size for bacteria or not. So if we're doing the interpretation manually, it's very difficult to understand whether it's a bacteria or something else or some debris. There's a lot of debris in these images. So we have a resolution challenge where the features that we're trying to image are very small in terms of resolution. But we also have a gross resolution challenge. The entire whole slide image is of multiple times larger than what we were dealing with the fungal keratitis data set. Each image can be of few hundreds of thousands in resolution, and it's very challenging to work with this sort of images. And for this reason, we tried the same multiple instance learning framework that we had. We trained our own contrastive learning model, and we extracted the features. But instead of using 20x magnification, we're now using 40x magnification. This is leading to much more patches, even just by using a higher magnification. And then at the end of the day, this slide is wrong. You are trying to classify bacteria positive versus bacteria negative slides. But we were not able to reach any conclusive results. So essentially, I thought that it's either a problem from the aggregator or a problem from the encoder that we were using, the self-trained contrastive learning CNN that we were training. And unfortunately, I didn't have enough resources to scale up my training for a different kind of encoder. It already took multiple months to train this SimCLR model that we had, and I was pretty sure that it's not worth spending another year training another encoder and waiting for it, even though I was using a relatively powerful workstation. So for this reason, I decided to go for foundational models. I found online a recently published paper called Biomedica. Essentially, they trained a clip model on text and image pairs, and they trained it on the entire data set extracted from PubMed. Any image that shows up in PubMed, if it was a figure in any paper, they would extract that and they would feed it with the caption of the image into this clip model. And basically, I was now using a much more powerful tool at hand instead of using a self-trained contrastive learning algorithm, a CNN. I'm now using a clip model. And I retrained the same model and I reached very nice conclusions with a very stable learning uh, in a matter of few days. So it was a success for this paper. I decided for the sake of experimentation to compare the performance of the SimCLR we trained to the Biomedica clip that we had, as well as a combination of both. So what happens if we run our own model, in-house model, plus a foundational model that we found online? Uh, do we reach a better performance? Is it worth it for a lab to invest resources in training their own model in-house, or do they have to just take a pre-trained model and perhaps train an extra layer of neurons on top of it and call it a day? And this is what we obtained. These are three histograms that show the performance of a bootstrap on different metrics on our data set. On the left, we have the positive class F1, and then the weighted F1 in the middle, as well as the AUROC on the right. In most cases, the blue is the best model, which is the combined model of both CLIP and SimCLR embedders together. But it overlaps a lot with the yellow plot, which is the CLIP-only model. And if you do statistical significance, the CLIP model and the combined models are relatively the same. There's no difference statistically between these two models. And the conclusion is that in many cases, it may be worth it to just invest resources into searching for a powerful encoder or foundation model that's available online rather than spending a lot of money training your own models for these types of large AI dataset training. So, fortunately, we were able to obtain good results with an AUC of beyond 90% and an accuracy of 90%. So we also called this project a success, and to our surprise, it performed better than our fungal keratitis model, which had an AUC of 88% and an accuracy of 79%, even though that data set was much more simpler. The fungal keratitis data set was much more simple and much easier to interpret than a gram stain model, which only can be read by experts in the field. So, moving on from this project, we had a common problem that you were facing on these microscopy images. Microscopy is not a simple task. There is essentially a fluid that we're trying to image with a microscope, and the microscope can only see one layer at a time in focus. And unfortunately, many of our microscopic preparations are at least 10 to 20 microns thick. We are using a smear of fluids, even though it's one drop of water, but on a microscopic scale, on a micron level scale, these are multiple microns, and it may be difficult to image them. Some samples may be out of focus when we take the image on a microscope, but also we can have different material that's present in different planes in this microscope. And this can lead to us not being able to image all the material, all the sample, everything that's present in that sample, such as the image here on the right. So, is there a way we could use artificial intelligence to reconstruct these images that are distorted from the microscopy imaging process? From my optics and ophthalmology background, I know that this is an optics problem. We are not able to image properly the sample because if we're looking at a material that's on a different focal plane, it is subject to blurs and distortions, and we call them optical aberrations. Optical aberrations can be computed, they can be analyzed. And I decided to create a computer vision model that can distort these images manually using my optics knowledge. So I induced synthetic distortions for these microscopy images to the point where the images were completely blurred. And then I trained a diffusion model to move from these synthetically distorted images back to the original images. And once we did that, we were surprised that at some point, when our models became mature enough and large enough, these original images if can be turned into a better image. If we apply these models on our original images, we can even remove the blurs present in these images and get a better enhanced image. And if we apply this on our microscope, uh, the image on the left is the gold standard image. It was imaged with a slight out of focus uh, uh, technique. And if we improve it with our AI model, it shows up as the image on the right. That's a different image here. And essentially, what we're saying is that we can now get a data set of whole slide images and convert them into better, higher quality images using artificial intelligence and using diffusion models. These diffusion models were successful in learning how blurs occur and how optical aberrations can shape up images, and they were able to reverse them to an extent for sure. What if uh, we evaluate these diffusion models on our data sets? Do they have any meaningful improvement beyond the visual? So what we did is we took the fungal keratitis data set that we had and we induced enhancement with our diffusion model to this data set. And then we retrained the same data set with the same labels on the same model. After our enhancement with the diffusion model, we obtained an accuracy boost of 4% and a specificity boost of 6%. The training was much more stable. We achieved this result within one epoch with no, sorry, within one trial without any parameter tuning. So it was very hopeful, and the conclusion was that this diffusion model that we're using is actually beneficial not just for in terms of visuals, but also in terms of unlocking data that was lost due to blurs by understanding the optics of blurs and reversing them. So that's essentially my presentation. I didn't want it to go over the scheduled time, but essentially it's very tough to summarize ophthalmology and ophthalmic imaging into certain topics or pillars because there are so many. I decided to go with microscopy and topography as two main pillars of my presentation because this is where a lot of my focus lies. And I believe there's a lot of projects invested in these two domains. Microscopy imaging is a whole field on its own. It's very popular. All of pathology is moving towards digitizing their images and trying to apply artificial intelligence models on top of them. Similarly, in ophthalmology, the largest focus of artificial intelligence is on tomographic imaging. And because the eye is such a transparent medium, we can image it and image multiple layers within the eye, which can be very useful for diagnosis, for treatments, for surgeries, and so on. Um, so my goal was to get people, as many people as possible, excited about this field. Most of ophthalmology is digital these days. It's one of the richest fields in terms of imaging. So there's a lot of potential for digitizing it, as well as combining it with artificial intelligence and computer science and computer vision for meaningful interpretations and diagnosis that will assist physicians and would be staples in machines all around the world. Uh, Thank you for your time. This was it. And I hope this was useful for a lot of you. Other, I think you have a problem with your speaker. So if that's fine with you, I'm going to end the meeting myself. Have a good day.